Thank you, Dr. Walid, for the nice presentation, and I think we are open for discussion, so we can have the panel. The panel is here, and Dr. Shahla is here also. So please, for the audience, put in your questions so we can then direct them to the panel here, and you can get the live answer, and we can do more discussion even with your questions. So until we get some questions, Dr. Dalal, do you want to mention anything?
Yes, first of all, this was a very rich session with really interesting presentations. So starting with Dr. Suzanne, I have a question on the 40% that we want to improve in increasing reach out of this education pre-Ramadan. What do you think can improve? Is it a no-show problem? Is it patients are registered, referred, and not seen? Or is it not done during the conventional visits?
Thanks for the question. I hope you can hear me.
Yeah. Yes.
All right. So I agree. It's often a challenge to make sure that every patient goes through the education. As mentioned, as you've rightfully pointed out as well, and I think Sheila also mentioned it earlier, that if the education is done in the clinic setting, then we are limited in terms of how much time we're going to spend on the patient. And so it won't be a adequately thorough education. So I think what would actually be good, and I think there are some groups that are already doing that, is that it needs to be included in the flow of the clinic itself, which means that it is actually part of the patient's journey for the clinic consult, which means that it might be not during the clinic consultation, but probably at the end. So that it's actually part of the whole journey, rather than a separate group session, but maybe together at the end of the journey. So, and I think you can actually use various means, like, like you have heard from Dr. Debbie Wick, right? You can also use basically online as they're waiting during the consultation, before the consultation or after the consultation as they're waiting. So there are various means to actually increase the uptake. But I think what we do need to think about is about making it convenient for the patient by providing various methods of delivery. Yeah, and with that, I think you can improve on the 60%, because I think that is actually quite some way to go to actually, increase at least another like 10-20% through various modes, all the way up.
I do have a question for Dr. Debbie. Dr. Debbie, do you believe with the current technology we have, and maybe in the future also, we can even improve or even, let's say, try to lower the risk for patients going for fasting during Ramadan, meaning patient at baseline status, they might have a higher risk, but with this instruments, we can even lower the risk so we can actually let them fast?
Yeah, thanks for your question. No, absolutely. Some of the work I didn't talk about today is work we're doing a lot around things like predictive analytics and using data and IT systems to better sort of automate the process of risk detection, and then potentially pushing people into sort of strategies that might be supportive and helpful. So absolutely, we've systems running across the UK and parts of the Middle East and Malaysia where, again, we're collating data from EMR systems, remote devices and so on, and we can actually use that data to start to actually build patient cohorts who we know from the rules and algorithms that have been developed are potentially at higher risk than others, and start working with them earlier to implement strategies, new treatments, and other changes needed to lifestyle or so on, so that they can be in a better position when Ramadan kicks in to be able to go and fast. But also even during Ramadan, that ongoing piece of monitoring, and we've now got fantastic sensors, ways of measuring glucose data pretty much real time, and I think building in more and more automated support into these sorts of systems as well will help people on a sort of day-to-day, hour by hour basis. But yeah, I think there's huge potential to do exactly that.
Perfect.
And maybe we ask our guest speaker here today with us, you can use the mic next to you, was the reason, again, for not testing or testing less than before Ramadan or maintaining the same habit analyzed? Is it cost? Is it not believing, not knowing?
I think it's a combination of everything. It's a little bit of everything. Of course, sometimes to I think it's a little bit of everything. It's not a single factor which contributes, and these factors may be very individual and different to different individuals. For example, sometimes some people may be very busy with spiritual practices during Ramadan, and they believe that they do not want to concentrate on their health. For some, it may be the cost which matters. Some simply don't want to know during Ramadan. Some of my patients will say, okay, ma'am, we just don't want to know what our sugars are like, because Ramadan is 1 month where we do not want to really worry too much about our health. And I think to some extent, it's also we need to work a little more on educating our patients also. So I think it's a combination of all these factors which finally are going to make a difference as far as monitoring is concerned. And in the last survey that we did, still our patients have the fear that the prick is going to invalidate the fast. So unfortunately, that myth also is still around the place. So we still have a lot of work to do.
I do have a question for Dr. Rachid. You're with us here. So you've been talking about the frequency of testing for glucose in patients. So for example, if we have a larger group of type 2 diabetics who are not on basal bolus therapy, they might be on a basal only or multiple oral therapies, and they're doing the regular checks as needed in the beginning of Ramadan, and then eventually they start to make this event or make this checking actually less and less during the month, since they notice that their glucose is very stable and that they're not prone for hypoglycemia or hyperglycemia. Do you think this is an appropriate recommendation to do for patients? As days go by and not having any problems, maybe you can reduce the number of blood checking?
Thank you for this question. It's very, very important. I think it's decision for making and the number of or the moment to check the blood glucose depend of the profile of patient and the recommendation and the risk scores. But in the practice, in the reality, there are many condition for patient and for practitioner, and for some bodies, we have, for example, patients who are only in metformin, and they need blood glucose monitoring during Ramadan, but because they say that they have to do it because for the safety. And for insulin, basal insulin, we need minimum 1 or 2 blood glucose checking during Ramadan. But it is the suggestion of the practitioner and for doctors. But I think it's the principal suggestion or recommendation is to speak and to listen to patient, and with the patient, we according the decision and the number of self-monitoring blood glucose during Ramadan. It's not the same for all patients. We have to have you individual the check monitoring during Ramadan. Thank you.
Thank you.
I think we'll also take questions from our panel of experienced experts we have here in the room, so please go ahead.
Thank you very much. I'm Amir Babikra from Saudi Arabia. Question to Walid Kaplan. You know, Walid, most of the studies have been presented, that's before the era of the smart pumps that talks to these CGMS. And when we have these hyposuspension pumps now, and we have the autocorrection as well from some of these existing pumps now, we may need to revisit some of our investigations or research now to see how useful are these new devices in helping the patients to continue their fasting to the end. Because most of these hypos can be avoided. It's just dealing with the basal rates, except the ones very near to sahur time. Any comments on that or your views about this, please?
Yeah, hi Amir, how are you? I totally agree with you. The topic was not to discuss the pump and CGM in combination, but I think there are many studies, and Nancy in Egypt is leading in showing the benefit of using the pump with CGM in combination, A, to increase the number of days that can be fasted, and B, to enhance the safety of fasting. So yes, I totally agree with you. And if you just be patient to listen to my next presentations, I did actually highlight the fact that older studies does not apply to what we use nowadays because the setting of insulin management has been changing remarkably over the past 10 to 15 years. So we need to take that in consideration. I do agree with you.
Yeah, there is another question. Please go ahead.
Thank you. The data about the glucose monitoring is remarkable, but looking at the other side, we should question if our patient is not doing it, are we asking for too much? So who in the real life will do 7 times per day for 1 month? So just to elaborate, the guidelines recommended the times on which you should check. So maybe 1 time per week you can check before iftar, 1 time per week you can check 2 hours after iftar, with the focus in mind how to adjust the dose, which is the purpose of monitoring, rather than doing 7 times, and 7 times are good, why should I do it again? So I think we should relook into this data as well. The guidelines are recommendation to suggest what are the best times to check. So somebody is checking at the odd times and finding my blood sugar is good at the midday, so I don't have to do anything without checking pre-iftar or post-iftar or pre-sahur. So I think we should go back into that and then ask ourselves the recommendation. The second thing is the same as we said. When we talk to the patients in the pre-Ramadan education, which I usually do with my patient, is I ask them to bring the chart before the Ramadan starts. And then I can guide them about the dose adjustment and everything. If they are checking and keeping it with themselves for 1 month, it doesn't serve the purpose. Thank you.
Thank you, sir.
Assalamu alaikum. Jumal Kabi from UAE. My question to Dr. Rashid Malik. Regarding the study you quoted in Algeria of around more than 600 patients, and the mean testing of cell monitoring glucose before Ramadan was 3.6, and during Ramadan it was 2.6 or 2.5. So during Ramadan, when you anticipate the patient to test more, they're actually testing less. So what type of patients are they? Are they type 2 diabetic patients? And what is the pattern during the month? Was it testing more initially and they fade away?
Yeah, thank you for your question. This finding, it's about our study in 2019. And this is the first finding for Ramadan in Algeria and fasting. And we are surprised to see that in Ramadan we have less checking for blood glucose. And the problem is that after the meal after iftar, the patient don't check their glucose sugar because they are afraid to have hyperglycemia because diet is not respected. When we improved our education, pre-Ramadan education, 2 years after this first study, you have more patients, 1,647 patients. We are conducting in 2021, and after a good improvement of education, we are increased the checking of blood glucose in our patient, and we have improved also the moment and the number of blood glucose in our patient. We have not the same result for the first study, but we have improvement, and this is the conclusion of the study that the patient during Ramadan need to repeat pre-recommendation before Ramadan. And when we have a good suggestion, when we have a good the discussion with patient, we improve the self-monitoring blood glucose in during this month. And the practitioner also have the same recommendation and improve the recommendation and the suggestion of self-monitoring during Ramadan. In conclusion, when we compare the two studies, we have more self-monitoring blood glucose in Ramadan between the two studies, and we have improved that the monitoring glucose during the fasting hours, during the day. Thank you.
So I was going to comment on Dr. Salma Maher's talk that I personally use Darsafa a lot during Ramadan for my patients with or without diabetes, and it will be interesting to look at that in people with intermittent fasting because it's such a wonderful, reasonable plan to use, and that will reflect on what we've heard in the introduction of using the same kind of concepts for people across faiths. Dr. Hassanin.
Let me comment. I entirely agree with you. The concepts and the Darsafa program helps people during fasting, but at the end of the day, suhoor can be breakfast and iftar can be the main meal. I have a question to my dear colleague, Dr. Suziani bint Zainuddin from Singapore. You're heavily involved in the area of patient education, and many people across the globe in their clinics are very busy. So what in your mind is the good time for an educational session to provide the essentials of Ramadan education in such busy lifestyle, whether for people with diabetes or whether for healthcare care providers? Thank you.
Thank you, Professor Sanin. So it's a bit stressful, getting a question from the expert himself. Okay, so yeah, so I think Hassanin himself know that there are quite a couple of actually different teams are already testing out different methods. I mean, Sheila and team, and also I think Prof. Madani and team. I think that various teams here are already testing various methods. What I think we discussed before is that there are several modes, and probably we do need to individualize based on different groups. But what seems to be, I'm sure is a common common way to get around it is probably to look into how we can make it very convenient for the patient. So what probably is useful is that not only do we look into having this education like 6 weeks before Ramadan, but probably put it in their whole care plan, diabetes care plan. That means if, they have been regularly diabetes patients under whosoever care, then put it into their whole care plan in advance, which means that if you're going to see them this Ramadan, we do plan them in advance, how frequently their appointments are going to be, and then try and optimize them even prior to Ramadan period, before Ramadan period, to ensure that they have their general diabetes skills and education all in place, and then time them such that by the 3 to 4 months prior to Ramadan, you're already planning them towards preparing for Ramadan. So that's in terms of timing. In terms of mode, and method of delivery, as I mentioned earlier, it will be good to actually include it in the whole patient journey. So throughout the year, you're already dealing with all sorts of diabetes management that needs to be done. But right before Ramadan, you look into what was the fasting risk all this while, because they may also be doing fasting throughout the whole of the year, right? Not just Ramadan. You may be doing voluntary fasting after Ramadan, twice a week and also. So probably look into all this even before it starts, before Ramadan starts and before the 3 months of Ramadan. So go through that and then right just before Ramadan, reevaluate their risk, because their risk is going to change every year. So I think if we do it more, we don't fix it such as only like just before Ramadan that you think about it, but it becomes part of their whole diabetes care plan throughout their life and also throughout the year, then I think it becomes something that is basically incorporated into the whole diabetes management. And that probably will ensure that we get a lot more patients into the Ramadan focused education, because it becomes just part and parcel of their whole diabetes management.
So we have to conclude, but if you have a very quick question, we can get a very quick answer from the panel. Go ahead.
Yes, thank you so much. Salam alaikum, everyone. Thank you so much for this very interesting lectures, and especially about the education, maybe also digital education. But what also grabbed my attention is there any plans also to include pre-diabetic patients and diabetes prevention in such education, especially during Ramadan? Thank you.
Dr. Suzani, very short answer, please. Thank you.
I think at the moment, we are still trying our best to maximize the education for the diabetes patient themselves. So I don't think there's particular focus looking into pre-diabetes patients. But definitely that's a good thing to highlight, and we should actually incorporate that because we do need to manage them. Certainly, that's all right. So, yeah.
Thank you so much. Thank you for our great, excellent panel for their excellent presentation. Thank you for the audience for helping out with the questions. And definitely, Dr. Delar, my co-chair, thank you so much for participation. We thank